Hi, everyone. This is Elizabeth Flower-Bash at CLASP. We'll give it just a moment for people to join us, but thanks so much for joining us today. Hi, everyone. Thanks so much for joining us. I'm Elizabeth Flower-Bash. I direct the Income and Work Supports team here at CLASP. While we're getting started, let me just introduce you to CLASP in case you don't know. The Center for Law or Social Policy, or CLASP, is a national, nonpartisan, anti-poverty nonprofit advancing policy solutions for low-income people. We say we develop practical yet visionary strategies for reducing poverty, promoting economic opportunity, and addressing barriers faced by people of color. With 50 years experience at the federal, state, and local levels, we're fighting back in today's threatening political climate while advancing our vision for the future. We're really excited to have you here for this webinar today, where we bring together two topics that we're really passionate about, Medicaid waivers, and particularly the ones that deny access because of people's inability to meet work requirements, and using a racial justice agenda or lens to move this agenda. We know that effective anti-poverty advocacy requires that we identify and remove the array of barriers that block low-income people from economic justice and opportunity. Only then can we fulfill the American promise of equity and opportunity for all. CLASP is committed to a racial equity agenda that strengthens equitable public investments, promotes economic opportunities and security for all, protects civil rights, addresses explicitly the challenges of immigrants and their families, and honors the voices of communities of color. So we've got two great presenters today. Let me start by introducing Renato Rocha, who's going to be speaking first. Renato Rocha is a policy analyst within CLASP's Income and Work Supports team. He focuses on issues regarding work requirements as well as access to public benefits for immigrant families. Prior to coming to CLASP, he was an economic policy analyst at Unidos US, formerly the National Council of La Raza. He holds a master's in public affairs degree from Princeton University's Woodrow Wilson School of Public and International Affairs. So he's going to present, and then I will come back and introduce Dr. Michener, who is our second presenter. While Renato's getting his slides up, I will say that you're all in muted mode, but you can use the chat box on the side to ask questions, and we are saving time at the end to make sure that we get to ask and discuss some of those. So thanks so much.
Hi, everyone. My name is Renato Rocha, and I'm a policy analyst on the Income and Work Supports team at the Center for Law and Social Policy. Thank you very much for joining us today. One of my primary roles at CLASP is to help fight back against proposals that take away health care from individuals who don't work a certain number of hours per month, or also known as work requirements. And just a slight disclaimer from my portion of the presentation, you'll sometimes see work requirements in shorthand, or you'll see the term work requirements in quotations. But what I would really like folks to know is that that term is really an effort to take away healthcare in the context of this conversation, or other assistance programs from individuals who don't work a certain number of hours per month. Before I get started, let me just provide a quick roadmap of my presentation. I'll first discuss what are work requirements, then begin a discussion about their deeply rooted history in trying to tie proposals of work requirements to the receipt of public benefits and the nature of race in that conversation. I'll then discuss the nature of low-wage work, provide a landscape of Medicaid waivers, and lastly, go through a few of the negative impacts of waivers on Medicaid beneficiaries. So, what is a work requirement? So, it can be described essentially as rules that take away cash, food, housing, or in the context of our conversation today, healthcare from people by conditioning eligibility on the following two criteria. One, it's working or participating in other qualifying activities, such as volunteering or attending school for a certain number of hours per month. That can be 20 hours per week or 80 hours per month. It could vary by state. And the other important criteria of this rule is the accurate and timely reporting of those hours. That's to say, if an individual is, clearly meeting the minimum number of hours per month, but they aren't accurately or reporting those hours on a timely basis, they could be found in noncompliance of the policy. Also, depending on the program for a particular state, some beneficiaries who lose benefits may also not be able to re-enroll into the program. Before I go into more detail of Medicaid waivers in the following slides, I'd like to provide some important historical context of tying work to receipt of benefits. The Trump-era proposals are based on dog whistles and stereotypes. For instance, President Trump signed an executive order this year directing federal agencies to review adding work requirements to assistance programs, which he said would increase self-sufficiency, well-being, and economic mobility. Seema Verma, head of Centers for Medicare and Medicaid Services, said they would improve health and well-being through work and community engagement. The proposals invoke a racialized stereotype that dates at least as far back as Reagan's fictitious welfare queen, influencing the public to believe that welfare made people dependent. The same stereotypes continued into the 1990s as reform added work requirements to cash assistance and limited food assistance by non-working childless adults. Today, the administration continues these racialized dog whistles and stereotypes, including through current attempts to make changes to the nutrition title of the Farm Bill. For example, the excerpt on the left of your screen is a recent study that found that white Americans were more likely to support cuts to benefit programs when they believe their status is threatened, or when they believe that communities of color are the main beneficiaries of programs. The tweet on your right of the screen illustrates just how groups like the American Enterprise Institute are communicating their support for work requirements. As Rebecca Vallis of the Center for American Progress effectively tweeted on social media, the image of a Black woman behind or in front of an Obama sign holding 1980s era food stamps is a clear image of today's dog whistle politics. The bottom line is that racially loaded language very much continues today. The tweet from the American Enterprise Institute, as you'll see on the mid to bottom left of the screen, was tweeted just less than a month ago. To be clear, proposals to take coverage away from people who don't meet work requirements are grounded in false assumptions that people who aren't working need rules to work. The truth is that most recipients who can work are already working. As we can see on the bar graph on the left, approximately 78% of families with Medicaid coverage are working part-time or full-time, and an estimated 60% of recipients are working themselves. As we can see with the pie graph to your right, the main reasons for not working is a reported illness or disability at 36%, taking care of home or family at 30%, and going to school at 15% among non-SSI adult Medicaid enrollees. Historically, Medicaid does not allow work requirements as a condition of eligibility, and we at CLASP also firmly believe are illegal. However, in the Trump era, CM is encouraging states to apply for waivers that include work requirements. Since a letter that was issued in July, waivers have been approved for Kentucky, Indiana, Arkansas, and New Hampshire. For Kentucky, litigation has invalidated their approval, and a similar lawsuit is underway in Arkansas. However, I'll note that the work requirement waiver has already been implemented in Arkansas. Also, about 10 other states have submitted requests or likely to follow, as several are still at the state level. For example, Oklahoma, Virginia, and Tennessee. It's also important to note that Medicaid waivers do not require states to offer jobs or work activities to participants, and CMS has said that Medicaid funds cannot be used to provide such services. Work requirement proposals are incredibly hurtful to all states. I'll just make that clear. In non-expansion states, however, proposals to take health coverage away from parents who don't work a certain number of hours per month are extra harmful. In these states, like Alabama that has an open comment period, the proposals create a catch-22. That is, even parents who can comply with the requirement would lose coverage because their income would rise above states' low eligibility limits. So far, CMS, the good news is that CMS has not approved Medicaid work requirements in these states. So what do we know from TANF and SNAP? As mentioned, work requirements are already in place in these two programs, and a body of literature has been established. From this work, we know that the main effect of these proposals is to make it harder for people to access and keep benefits. We also know that mandatory work programs have little effect on employment and earnings, and use up resources that could be used to provide more or better support services or higher quality training. Most participants also continue to work in low-wage jobs with unsteady hours, no health coverage, and little to no opportunity for advancement. So in this next slide, before I go through who loses benefits, I'll flag that in the following slides, I'll dig a bit deeper into some of these groups. To be clear, with no legislation in place for work requirements in Medicaid, states are making their own rules, and their rules look different from one another, so the effects can vary by state. But people who lose benefits include those who find it difficult to secure employment, people working but without much control of their schedule, people who struggle getting through the red tape, people with disabilities, and people with caregiving and school-related responsibilities. I'll also, is not on this slide, but another unintended consequence of these policies is the unintended consequences on children who could lose coverage if their parents lose coverage for noncompliance with a work requirement. Simply put, we know that kids are more likely to be uninsured if their parents are insured. So for our first group that I'll go through, people may struggle to find work because of recessions, histories of justice involvement, or they reside in areas of high unemployment. This next slide shows that unemployment also varies considerably by race, ethnicity, and educational attainment. For Black people, unemployment is considerably higher compared to all other races and ethnicities and across educational attainment groups, adding to the evidence of the disproportionate impact of these policies on communities of color. For another group, these proposals do not reflect the realities of today's low-wage jobs. For seasonal workers, for instance, these workers may work more than 80 hours per month or more than 20 hours per week for several months out of the year, but for a few months, they may fall below that threshold and may turn on and off the Medicaid program. For another type of worker, they may expect to work 20 hours per week or 80 hours per month, based on their scheduling. But since they don't have complete control of their scheduling or no control of their scheduling, a sudden change in their schedule may put them below the minimum threshold for that state. Taken together, these conditions of low-wage work make it extremely hard for people to access and maintain health coverage. With regards to the graphic on the right, in addition to the racial disparities, I'll note that women are disproportionately more likely to work part-time. On to another group. Even when Medicaid beneficiaries are meeting the work requirements, people may lose benefits due to failure to submit paperwork to document their hours of work. The National Kaiser Family Foundation report, with findings that between 1.4 million to 4 million people would lose coverage due to work requirements, also finds that the majority of coverage losses are due to paperwork issues and barriers rather than ineligibility for Medicaid. The report finds that even in their low-end estimate of people losing coverage, 62% of those losing coverage would be working or exempt, meaning that their coverage losses would be due to red tape and paperwork rather than a change in their eligibility status. With this next slide, let's take a quick look at the evidence of bureaucratic barriers in Arkansas. With Arkansas a few months into their implementation of work requirements, evidence is quickly building for the harsh effects of red tape on health coverage. Arkansas requires people to report their hours of work by the 5th of every month through an online portal. This puts individuals who may not have access to the internet or individuals who may find it hard to find the online portal or even navigate the online portal at a serious disadvantage. As of September 1st, over 4,300 Arkansas Medicaid beneficiaries have lost their coverage because they didn't report at least 80 hours of work for each of June, July, and August, which accounts for approximately or nearly 20% of the people who, in that first group of individuals who were subject to work requirements in Medicaid. And we expect moving forward that a similar number of individuals will lose coverage each month. And on to our last group. With the evidence from Arkansas clear that people are losing health coverage, take another quick look at this pie graph that I shared earlier in the slides. The top reason for not working among non-SSI adult Medicaid enrollees is reported illness or disability at 36%. Lots of states will tell you that they exempt people with disabilities in their applications for this demonstration waiver. However, we know from TANF that people who don't have access to SSI and may not be able to work are not likely to receive an exemption because of the complexity of paperwork or the burden itself of paperwork. In conclusion, I'll note that opposing work requirements does not mean you are against work. Many people desperately want work and just need the opportunity. But the proposal states are putting forward is the answer. Mandatory programs are wasteful and focus on attendance and not on outcome. These programs put pressure on states to serve lots of people. They're more likely to run low-touch programs and less likely to focus on high-quality services that benefit clients' lives. For example, one study of TANF caseworkers found that they spent more than half of their time documenting participation and not focusing on important outcomes like getting clients jobs. We know what works. The most effective job training programs are intensive and higher cost, but pay off in long-term gains. And if policymakers were serious about helping people work, they would provide more support services like childcare and transportation, and certainly not take away people's health care. And with that, I conclude my portion of the presentation. Thank you for your time. For more information, please see our website here, and also feel free to contact me directly. And I'll now pass it back to Elizabeth to present our next speaker.
Okay, so let me introduce Dr. Jamila Michener, who I am really grateful has taken the time to be with us today. Dr. Michener is a professor in the Department of Government at Cornell University, where she studies the political causes and consequences of poverty and racial inequality. And she's author of the recent Fragmented Democracy, Medicaid, Federalism, and Unequal Politics. This research has been supported by the Woodrow Wilson Foundation, the Russell Sage Foundation, the NSF, Robert Wood Johnson, and the Ford Foundation. And it's really exciting to have her here today because she's really engaged not just in academic research, but in thinking about how to apply that academic research to real life issues and how to bring it to a broader community. So she is co-leader of the Finger Lakes chapter of the Scholar Strategies Network, which is focused on bringing academic research to policymakers, civil associations, and the media. And her writing has been featured on the New York Times, the Washington Post, the American Prospect, Wisconsin Public Radio, New York Public Radio, and Vox. If you haven't read it, I highly encourage it. Professor Michener also sits on the advisory board of the Cornell Prison Education Program and teaches in local correctional facilities. She received her MA and PhD from the University of Chicago and her undergraduate degree from Princeton University. So I'm really excited to hear from her. So let me pass this to Dr. Michener to share with us.
Let's see if okay. Does that, can you hear me?
We see you. Yep, all right. Perfect.
See and hear me. All right, so I thank you all for being here and for everyone who's listening in, and also to the folks at CLASP for inviting me to come and speak with you guys. I'm gonna try to keep this relatively short. I'm really keen on hearing questions and having some engagement from the folks who called in. So I am going to base a lot of what I say in the next 8 or so slides, and I'll move through them relatively quickly, on research that appears in my book, but I'm also going to kind of supplement that with a few things, with insights that I've garnered in the last year since the book has been out, and that I've garnered in particular from engaging with Medicaid beneficiaries and advocates, activists, and even bureaucrats. So I did a lot of that for the book, a lot of qualitative and quantitative work that allowed me to kind of think about the perspectives in particular of policy beneficiaries, of Medicaid beneficiaries. But I've also done a lot since the book has come out. And so there's just a ton. I'll give you what's really just a snippet. But I want to say, kind of following on Renato's presentation, that, you know, he gave us a lot of compelling information about the work requirements, and I'll return to the issue of the work requirements at the end of this presentation. But one of the questions that always looms for me, and it loomed for me before the work requirements were really a thing, that was on the table as a concrete possibility, but you know, has loomed for me beyond the work requirements for a long time and motivated a lot of this research, is that when we think about policy environments, social policy in particular, whether it's healthcare policies like Medicaid or other kinds of social policies that matter to us, and for me, that's Medicaid, but it's also a bunch of other things. We look at the kind of landscape as it is, and we look at the landscape as we would have it be, or as we think it should be. And there's always the question of how do we get from here to there, right? And so we get a lot of information about things like Medicaid work requirements and the ways in which they are a policy designed to solve a problem that doesn't exist, and that a kind of policy that can create more problems, right, than anything else. And the question is, what are the political levers for preventing these kinds of policies from being enacted and from taking hold? And really, as a political scientist, my answers are about politics, and in particular, I focus on not as much on what we tend to focus on these days and on what is really important, which is what's happening in Congress, what's happening with the president, what's happening in these state legislatures. All of that is really important. But the perspective from which I think about this question of how do we create a political context that is conducive to policies that are beneficial to the most vulnerable among us, I think about it from the vantage point of the role of the actual people who have the most at stake, right? The role of the policy beneficiaries themselves, the role of people who are living in poverty, people who are disproportionately Black and Latino. How do we understand what voice they have in the political process such that they can play a role in creating a protective political context that where there are barriers to some of these less desirable policies passing? And a lot of my work is thinking about that. And the book really thinks about that from the perspective of Medicaid, right? And what my kind of point of departure is this period in 2009 when I first started to really think about this through the vantage point of Medicaid, where it felt like we were in sort of the best of times with respect to healthcare policy. The Affordable Care Act was on the horizon and was about to be passed, but in many ways also felt like we were in the worst of times in terms of polarization and kind of negative forms of partisanship and the kind of under participation and under inclusion of people who are living in poverty and people of color in our political system more broadly. And I wanted to think about how Medicaid, what the implications of Medicaid were for democracy and for the political engagement of actual Medicaid beneficiaries, in part because I care about the political engagement of people who are at the economic and racial margins, and many of those people are represented within a program like Medicaid. And so I started to really try to understand how Medicaid matters politically in people's lives. And when I first started to talk about this question, folks would say, you know, if we're going to talk about the politics of Medicaid, we need to talk about Washington or we need to talk about state governments. But Medicaid beneficiaries themselves aren't really that big of a part of the conversation. And that wasn't a kind of formulation that I could readily accept. I wanted to know more. And that's really where the book came from. And one of the things that I did, there's a lot of different kinds of methodologies that I use in the book. And some of it is quantitative and it's using administrative data and survey data, and some of it is qualitative. But the picture that emerged initially for me when I started to do qualitative work and talk to Medicaid beneficiaries all around the country was a set of experiences with Medicaid that involve some negative things. And I give examples on the slide of beneficiaries I interviewed who talked about things that indicated stigma, indicated negative interactions with bureaucracies. And so I thought, it looks like there are aspects of Medicaid that are challenging for beneficiaries. At the same time, I was very much struck by the ways in which Medicaid beneficiaries that I spoke to expressed gratitude for the program, made it clear that Medicaid, for many of them, had saved their lives, had saved their children's lives. They very much valued Medicaid, and they very much understood that the program was crucial to their well-being and to the well-being of folks like them. So there's just really this mixed feedback that I got from beneficiaries about a program that could be challenging to navigate and that sometimes was an alienating program to be a part of socially and politically, but also that was vital in their lives. And I really wanted to understand what all of this might mean about the relationship between Medicaid enrollment and utilization and political outcomes, things like voting, registering to vote, and participating in a range of other kinds of political activities, working for a campaign, participating in some civic or political group in your neighborhood, a real range of activities. And I got my hands on some survey data, a large survey called the Fragile Families and Child Wellbeing Survey that, unlike many other surveys, has a significant representation of Medicaid beneficiaries. So of about the 9,000 people surveyed, across the country in the fragile families data, 55% of them are Medicaid beneficiaries. Now, most national surveys don't have that many Medicaid beneficiaries, but because the Fragile Family Survey focuses on people who are living in poverty and people who are sort of economically vulnerable, it has a really significant number of Medicaid beneficiaries that are interviewed. And this is the survey I turned to try to get some breath, to try to understand the relationship between Medicaid enrollment and experiences with Medicaid and outcomes that have to do with our democracy, who's participating, who's engaging civically and politically. And what I found was that people without Medicaid were more likely to participate in a range of political activities when we compared them to people with Medicaid. Now, of course, the kind of bivariate correlation between these things is not surprising. People with Medicaid have a lot of challenges and disadvantages that would make them less likely to participate in politics, right? And so that could just be because of poverty or because of other economic disadvantages, and it could have nothing to do with Medicaid itself. And so one of the things that I did was I just accounted for a real range of stuff. And I won't get into the details of this and show you big charts with numbers, because I think that is sometimes a little counterproductive to the richness of the discussion. But through a variety of methods that allowed me to control for other factors, that allowed me to kind of have expanded models that accounted for some of the challenges that people who are living in poverty face in their lives, and allowed me to match people so that I could find people in the Fragile Family Survey who in many ways, in terms of age, education, income, and other background factors, race, looked like another set of people in that survey, and that the only observable difference between them was Medicaid. When we compare those people so that we try to get a sense of what work Medicaid itself, experiences with the program themselves are doing, so that I could understand if Medicaid policy as it was structured was potentially helping people, obviously, in tremendous ways with respect to their health care, but demobilizing them in other ways, right? This was what I was really interested in understanding. And so all of this statistical finagling essentially confirmed what the initial bivariate relationships that I showed on this previous slide showed, which is that being enrolled in Medicaid is associated with being significantly less likely, and that's 3 to 8 percentage points, to participate in a range of different forms of politics, political activities, right? And this is holding constant a lot of the other factors that we would think would explain these disparities. And so when I first found this initial finding, people said to me, well, hold on now. You have to think about the implications of this. If you're saying Medicaid is bad for democracy, the folks that want to cut the program are going to love that. They're going to pick that up and run with it and say, look, this is making people apathetic and not participate in democracy. And it was very important to me to make it clear, and I do this in the book, that is not the takeaway, right? And one of the reasons it's not the takeaway is because I didn't stop there. As I talked to more and more beneficiaries across the country, I tried to get a sense of what was going on. And people explained their experiences to me in ways that made clear that where they lived was very, very significant. So this is a woman named Terry, who I interviewed in Georgia, who told me about her son. Before Terry said this, all I said was, tell me about your experiences with Medicaid, nothing else. And she immediately jumped to how the programs are inconsistent across place, right? And she tells me Ohio is the easiest. They care about their people. California, the process is fast, but there's a lot of people. It's rapid. It's out of control. In Georgia, all the benefits that you can get are limited, and it's a very kind of restricted context. And she went on, because she had lived in a number of different places, and she went on to tell me about each place that she lived and how different Medicaid was in one place from the other, and how that difference mattered for how she thought about and felt about herself as a kind of political being, an agent, right? She even got upset. I mean, I was really struck by how emotional beneficiaries were when I talked to them, how much this meant to them. And she told me a story about her grandmother who had come from Chicago to visit her and could not get her prescription filled, right? And she was really stunned by the fact that Medicaid just didn't carry, it didn't transfer from place to place, and it was so different across places. And the thing that I took most from my interview with Terry, and after this, it really, the more people that I talked to, the more strongly it came to the fore, was that from this kind of cross-state variation, and not just cross-state, but within state, right? The fact that one year you can have access to some set of benefits, and the next year the policy changes and it's taken away. And one year the bureaucratic process can be structured one way, and the next year the rules are all new and the bureaucratic process is different. This kind of arbitrary change, both across place and within places over time, Medicaid beneficiaries expressed to me an understanding that it was political, right? So Terry said, if it was about helping people, you would say, yes, let my state be more productive and healthy so we don't have people losing their lives and so they can be productive citizens, right? And when I asked Terry, well, you know, is there anything you can do about this? Is there anything other Medicaid beneficiaries can do to engage, to play a role in changing this system? She sort of stared at me and she said, white noise. And there was an awkward silence. And I said, okay, what does that mean? And she said, white noise is the people that choose to say, well, if they give it to me, they give it to me. If they don't, they don't. White noise also means that you feel like in your world, you have no say in the process. If you don't agree with what's going on in Medicaid, it's demeaning the process. I've never seen anyone really stand up about Medicaid. I don't know why we don't fight. I give Terry as an example here, but I could give you 10, 20, 30, 40 other examples from these kind of in-depth conversations that often went for an hour, sometimes 2 hours, sometimes more. And it was Medicaid beneficiaries expressing their understanding of what they were getting, both that there was a degree to which Medicaid was both life-saving and arbitrary and capricious in the way that it was implemented policy-wise and bureaucratically. And two, that mattered for how Medicaid beneficiaries understood government, politics, and their place in the political world, and whether or not they actually engaged, right? One of the things I returned to some of the quantitative data to see, I realized, well, people are telling me that it matters where they are, that the kinds of benefits they get in particular places shape the decisions they make about engaging in political life. And so I went back and I wanted to see in the Fragile Families data if that initial negative relationship that I found between Medicaid enrollment and political participation varied across states. And what I found was it did. Now, keep in mind, this data is from around 2005, so it's not post-ACA data, and it's not the most recent data. And in fact, the Fragile Families survey is a longitudinal data set over time, but in their most recent data collection period, they didn't ask questions about political participation, so I had to use a kind of previous year. But as of 2005, and the key point for me here is how this varies across place, there were certain states like New York, California, Virginia, those states below the red line, where there was a negative relationship between Medicaid enrollment and political participation. There were other states, all the states that crossed the line, where the relationship was neutral. It was null as far as that data set could tell. And then there were states like Wisconsin, and remember, this is not the present, where there was actually a positive relationship, where Medicaid, being enrolled in Medicaid made you more likely to participate in politics. These are the only 15 states for which I had enough Medicaid beneficiaries that I could do within state analyses. So we don't see this, what this looks like across all 50 states. But the takeaway is that the structure of Medicaid policy on a state-to-state basis really matters for how Medicaid affects political engagement. Now, when I started to kind of pull apart what is driving these patterns, right? New York, California, Virginia are all very different. Why are they together underneath that red line? And why are states that we might think are even more challenging in terms of their Medicaid policy, like Texas and Florida, not below the red line? In the book, I kind of pull this apart and I identify a few factors that matter. And they're different factors in different places. And I won't go too into detail because I want to wrap up. But what I'll say is a few things. One is that the kind of nature of the benefits, and so the policies matters, right? So in states that in the last 2 years before that survey data was collected, there had been reductions of some sort. So even in states that are generous, like California and New York, sometimes they're relatively generous. Sometimes there's a reduction, right? Where either fewer people are eligible from 1 year to the next, or some policy benefit that was previously available is no longer available. You no longer get dental, or you no longer get podiatry, or what have you. And in the states where that kind of decline happened, there was some sort of reduction in policy or eligibility. That's where we see the most negative relationship between different kinds of political participation and being a kind of Medicaid, being enrolled in Medicaid. So it's not so much about saying these states are good and these states are bad, although there are certainly states that are better or worse when it comes to Medicaid generosity. But what I found really affected Medicaid beneficiary politically were changes. When suddenly something you were getting, you couldn't get anymore. And there's also recent research that's emerged that shows the opposite, right? There's some really recent research in the last 2 years that shows in states that expanded Medicaid, when people got more, it boosted political participation. They were more likely to engage in politics, right? And I have a piece coming out in a health policy journal in just a few months that shows that at times when there are major disenrollments, when thousands of people are disenrolled from Medicaid, in the immediate elections thereafter, we see a decline in political engagement and participation, even within places, within counties. So there's not like there's a ton changing. The thing that changes is that thousands of people are disenrolled from Medicaid, and that really demobilizes people. So when people are losing, when they're getting less, whether they're getting less or losing in a relatively generous state like California or New York, or whether that's happening in a state like Virginia, it is responsible for a kind of decline in political engagement. And there are lots of other factors that explain this variation, and I'm happy to talk about that. But the main takeaway, I think, that I would want to leave folks with is that Medicaid policy itself, it matters for a lot of reasons, for health and well-being primarily, and for other reasons. But it also matters because it can help to either create or undermine the political conditions that affect these things that we care about, whether or not waivers are going to be implemented, whether or not programs are going to be expanding. The policy itself creates the political conditions that affect its durability. And that this varies across place, so that challenging context can become increasingly so, and it can lead to a cycle of disempowerment in the places where Medicaid is being retrenched. Beneficiaries are being demobilized, and so there's less political leverage going forward for pushing back against that retrenchment. And that's essentially because a lot of voices are dampened. One of the things that I found is that in many of the states where these relationships were the most negative, we saw significant constellations in terms of race and class in ways that suggest that the folks who are most likely to be demobilized are people of color and people living in poverty. And so this kind of, I'll end here with, it's something that we should be thinking about as we think about the democratic implications of waivers. Waivers are going to create administrative burden. They're going to create experiences that signal a kind of arbitrary and capricious state and bureaucracy to Medicaid beneficiaries. 1 month you're covered and the next month you're not, and it could be just because of a few hours that you were not able, you're a few hours short of meeting the requirement. And the kind of administrative burdens and other experiences that both the waivers and other kind of 1115, the work requirements and other aspects of 1115 waivers that introduce burdens for Medicaid beneficiaries, these things are not only going to make it more likely that people are deprived of their health insurance, but they are also going to make it more likely that people are demobilized politically and that they're not a part of electoral and local state and local politics in a way that will help to build enduring coalitions that will protect against future erosion of Medicaid policy going forward. And so a lot of what I try to do is bring to the fore Medicaid beneficiaries as relevant political actors who we should be thinking about when we think about and debate and sort of brainstorm the challenges and downsides of policies like work requirements and of administrative and other processes, right? Okay, so Medicaid Matters for Democracy, and more broadly, I mean, political scientists have identified this in realms other than health policy, and I'm doing work that takes us into other realms of social policy. And policy matters for a lot of reasons, but it matters especially because it plays a role in empowering and disempowering people. And to the extent that we can realize that and think about how to work it into our own work, wherever, you know, you're all working from different vantage points, but to the extent that that recognition can play a role in how you understand the work you do, I think that it's a valuable point to keep in mind. I will stop there so we don't completely run out of time.
Hi, this is Elizabeth again. I do have some questions prepared for Dr. Michener, which I will start asking, but I also really want to hear from all of you who are listening. Unfortunately, on this platform, we can't unmute people to raise their hand and ask questions, but you can type in the chat box, and I will look to those for questions and comments and reactions, and we would really like to see them. Let's see if we can possibly hand the
Yes, I'm
view
trying.
back to me.
But
yeah, no, but okay. So, yep, I'll just go to my Q&A slide while I'm waiting for people to start to ask questions. So, one of my questions is that we have a lot of state policy advocates on the call, and I don't think it's news to them that there's a huge amount of variation across states. But in some ways, that variation is like the air. It's everywhere. They don't think about it. It's just the environment. What would you want them to take away from your research?
I think that I mean, so to a certain extent, and I've been learning this more and more as I've been talking to more state policy advocates in different places, that part of the answer to that question is going to vary a ton based on the specifics of place and of what organizations do and what ways they're kind of working to affect their local and state environments. But one of the kind of the main things that I want folks to take away is really in the context of your own work, I think thinking about are there ways that you engage that can kind of counter some of these processes? So this comes out a bit in the book, and it's come out more in work that I've done in the last few weeks, that I've identified what a kind of activist and engaged Medicaid beneficiary looks like, and interviewed a bunch of these folks across different states. And almost without fail, something that these folks have in common is a connection to an organization, some sort of advocacy organization that has provided them with a forum and a venue and mechanisms for their voices being heard. So, you know, I think if we're thinking productively about, well, how can we push back against this and make sure that Medicaid beneficiaries and other social policy beneficiaries are incorporated and sort of amplify their voices? I think that policy advocates and even Medicaid bureaucrats and folks who are engaging and interfacing with Medicaid beneficiaries on the ground can do a lot to both implicitly signal to those folks that, like, we're not just here to provide you with a set of resources and services, but we think of you and understand you to be an important political actor. And to the extent that folks are in positions where they can kind of actively be equipping Medicaid beneficiaries in that way, I think I would hope to just kind of sensitize them to that. And there are plenty of people that are already sensitized to that, right? And so this is just a different vantage point on what some folks already know.
Okay, thank you. I think that's a really thoughtful answer and gives me certainly things to think about as we move forward and partner with state organizations as well as others. I'm not seeing any questions coming in. I'm getting a little nervous that the chat panel isn't actually available for everyone. If people have questions and they can't get the chat to work, they can also email them to me. That's elauerbash@clasp.org, and I can look at them on my phone while we talk as well, or put them into the chat box. But I'm going to go ahead and ask another question while we're waiting. So we often focus on the negatives of devolving so much policy choice to the states, and certainly states like Texas and Mississippi provide a very minimal package of support, whether it's in Medicaid or other programs. But in a time like now, with the federal government so incredibly hostile to low-income people, and particularly to low-income people of color and immigrants, and that's certainly on my mind today with the public charge proposed rule having just come out, are there positives to federalism that, as a way to push back against bad federal policy?
Yeah, so this is funny. When I first started to work on this project, I think I had a pretty restricted view of federalism in the sense that I generally understood it, at least in the realm of healthcare, to be a negative thing because it produced so much geographic inequality that was arbitrary, right? That wasn't related to need or desert or anything like that. But that was, that was under a different administration. And toward the very tail end of writing the book, when I was kind of working on the kind of final parts of it, and it was clear that we were going to get a different administration, and that there were going to be things on the table that were just entirely different than what had been the case for the 8 years before that, it really challenged me to think about federalism not just as a hindrance, but as a kind of institution that is that has different constraints but also possibilities, right? And in this context that we're in now, I think that the possibilities maybe are a little bit clearer to see because there are states that can decide that they're going to do more and that can take action to sort of offset things that are happening at the federal level that may be less desirable. And so I think it's important to think about federalism in that kind of complex way. And I think there's, in one of the final chapters in the book, I really try to think about what are the ways that advocates, for example, utilize federalism. And in that chapter, I point out that federalism can be a challenge for advocates. It can fragment policy networks and coalitions. It can create different kinds of incentives and sometimes put, excuse me, advocates in challenging positions, but it also creates opportunities for learning. For example, I think having kind of networks across states where, and there are organizations like Community Catalyst, obviously, that they're part and parcel of making this happen, where there's possibilities for learning when things happen, and how can we make that happen here? What did the process look like in your state? And I think it means that individually, even in the context of a really relatively hostile federal administration, states can still think about what the levers are in their state to make things happen on a state and local level. And so all is not lost when the person who is less positive towards Medicaid wins the election. And so it just means there's more room for strategizing, for thinking creatively and innovatively within states, and for learning and sharing information and insights across states. And so those are some of the benefits of federalism that I think matter for a lot of folks. A lot of folks are enacting in their practices on the ground, honestly, is what I've seen and learned.
So I'm getting some questions coming in, and one of them was specifically from Kentucky and asking if you had some specific practices or tactics that you've seen groups deploy to increase the political engagement of Medicaid beneficiaries.
Yeah, so I absolutely, a couple of things. So one is that there are, and I saw a lot of this in the work that I did in Iowa, and it was successful in many ways, even though Iowa hasn't been an especially easy political environment for Medicaid advocates and activists. But one of the things that happened in Iowa, and this is a kind of broader point, is that in any state, there are a set of Medicaid beneficiaries who are better equipped to be engaged. So it may be beneficiaries, for example, who are from backgrounds that are more advantaged, right? Maybe they have a higher education level and they're a part of the program because they have a family member who has a significant illness or disability. Maybe they are, someone who is well educated, well employed, but came down with an illness unexpectedly and lost their employer-sponsored insurance and therefore ended up having to be a Medicaid beneficiary. The stories are myriad, but the fact is that in every state there are beneficiaries that are more empowered and better positioned, right? One of the things that I found that they did in Iowa well was that they connected those folks, and often those folks have very specific issues, right? And then they connected those folks and their issue and their concerns to a broader set of beneficiaries who were less likely to be engaged in the political process, who maybe had been Medicaid beneficiaries for nearly their whole lives, were more kind of traditionally people living in poverty, more traditionally people alienated from the political system, and kind of creating links across different kinds of beneficiaries so that beneficiary subgroups that are more advantaged, more well organized, more well connected, and are better able to kind of articulate their voices, that their strengths can be carried over to kind of sometimes recruit, sometimes train, sometimes stand side by side with and work with a broader set of beneficiaries who often are not brought into the process because of the difficulty of mobilizing them and equipping them to kind of articulate their political concerns to political elites and others. So I think one thing I suggest is thinking broadly about which beneficiary voices are mobilized and not stopping at the low-hanging fruit of the people who are just kind of easiest to get, but also expanding outside of that and using easier to mobilize groups to try to bring in and incorporate less easy to mobilize. The other thing I'd say is that like the administrative side of Medicaid matters a lot. And to the extent that either advocacy groups have influence over trying to shape the administrative process, or administrators themselves care to think about these sort of things, the easier that the application is, the smoother that your interaction with a bureaucrat is, the less kind of red tape and administrative burden, the more positive beneficiaries express their experiences to be, and the more they understand themselves to be people who belong, right? Whose comfort or whose feelings or ideas matter. And the kind of nuances of the bureaucratic experience of Medicaid are important for putting people in a position where they have any interest in engaging politically. And to the extent that that's something that active advocates or others can pay attention to and that maybe is within the realm of being able to affect, right? It's something that that I think matters. So there's more, but I want to make sure if there are other questions, we can get to them. I don't want to keep going on and on.
Thank you. That's terrific. And I really didn't ask her to make that point. Some of you know that CLASP has been very engaged with some of partners on administrative advocacy. We did get a couple of questions about whether you think your findings are generalizable to SNAP in particular, where there's somewhat less variation across states, and also to people who might not be getting Medicaid themselves, but whose kids might be getting it.
Yes, so the Fragile Families web data actually has both people who are getting Medicaid and people whose children or a close family member are getting Medicaid. And those results look the same, even if I separate out folks who just have a kind of 1 degree separation from Medicaid. If it's your child or someone in your immediate family who you're close to, the effects actually extend to those folks as well. So I do think on that count, the data that I have suggested is generalizable to that group. As far as you know, the question of whether it's generalizable to other policies, I think yes, but with some caveats. So there are other political scientists, Joe Sauce among them, who has done this kind of work looking at TANF. A really good friend of mine who is a professor at Duke is doing this kind of work looking at both WIC and SNAP. And the story that she has for SNAP is very much similar to the findings that I have for Medicaid, that it is largely demobilizing people for a different set of reasons, but nonetheless operating in the same direction as Medicaid. However, and me and her are working on a piece together about this, she's found very different results when looking at WIC beneficiaries. And part of the reason it's women, infant, and children. So part of the reason for that is some of the design of WIC bureaucratically and what many WIC administrators imagine themselves to be doing, which is much more about sort of incorporating people and help. We talk about it in terms of people changing versus people processing organizations and policies. So policies that are largely about processing people through and just giving them some benefit or not giving them some benefit, like Medicaid and SNAP and TANF, that's where we see these really negative relationships to political engagement. But in many WIC officers, they're doing something more than that with WIC beneficiaries. They're thinking about their nutrition, they're thinking about their children's nutrition, they're talking to them, engaging them in some more depth. Now that varies like even across WIC, but what we found is in general, there's something different going on with WIC. So on the one hand, we can't paint a broad brush and say every social policy is like this, or even that every means tested social policy is like this. But there are certain characteristics of policies that correspond to this kind of negative relationship with political engagement. And there are more policies that fall under that umbrella than there are policies that don't, frankly.
Okay. I know we are at time. I am going to take the privilege of asking one more question, and I know if people need to drop off, that's okay. But I know you've been submitting comments on the Medicaid waivers, and I was wondering if you could just speak a little bit to how you came to do that and why you think it's worthwhile. And also in the background, I just have a slide that shows how to submit comments as well. But let me ask you.
That's great. Yeah. So a couple of things. A primary moment for me was in the spring when I was on a panel and gave a talk at the New York City Bar Association. And there were some folks on the panel with me who were from the kind of legal end of things and had been working on some of these cases in Kentucky, for example, that was a specific example, who mentioned how useful the comments were in a legal context. And I simply hadn't known that. And so after that, I became much more interested in thinking about how I could contribute in that way. And I mentioned this to colleagues and found that one colleague in particular, his name was Phil Rocco, was very much interested in organizing a group of scholars who studied Medicaid who could develop well thought out research-based comments and tweak them for every different waiver that emerged based on what we understood about that state and submit them, right? So for me, once I realized that the comments actually mattered, that they could be used in a court of law and that they could be a kind of valuable part of the process and that they weren't just going to kind of be necessarily ignored by political elites who didn't care to hear what anything that was opposed to their preferred policy, that really motivated me to engage in that way. And now I encourage every and any when I can, and we've tried to submit comments for every waiver that has emerged in the last several months, and to kind of tailor our comments to the specific waivers. So there's some overlap in our comments, but it's not the same generic comment that goes everywhere. It really is kind of responsive to the nature of the policy proposed by the state.
Thank you so much, and I really do appreciate that you're doing it. I agree that it's incredibly helpful, especially when we get to the courts. There is a question that people would love to hear more, get the link to follow up on the research about WIC and SNAP. So I assume I can get that from you and send it to our participants.
Yeah.
And I think I will just ask the last question. If you have thoughts about it, this question about specifically many states have shifted to managed care systems within their Medicaid programs, and what we know about how that's affecting political participation.
That's a great question. And that is an area that I'm just now sort of delving into that I hadn't thought about much before. But a lot of the interviews that emerged in the book, this was a difference that people would point out. So I think a couple of different things, but I'll add the caveat that I've just now started to do some research on this, and political scientists really have not touched it. And I think in general, there are only a handful of political scientists who are thinking about the relationship between Medicaid and social policy more broadly and political participation and engagement. So a lot of this work is really kind of newly burgeoning. But one of the things that I found in the interviews that I did with Medicaid beneficiaries and that I continue to do is that one challenge with managed care organizations is that they deflect in beneficiaries' eyes the role of the government in the entire process. And so many beneficiaries, I encountered people who did not even know that Medicaid was a benefit they were receiving. And they would know the name of their MCO and think of that as like some sort of private corporation. And yes, it's subsidized by the government, but who thought about Medicaid as akin to private health insurance, except for low-income people, and that it was moderated through essentially private interests. And therefore, when they had a challenge or a problem with it, couldn't properly locate that the source of that was a kind of government-based policy. And what I'm really exploring is the implications of that. And my colleague Suzanne Mettler here at Cornell calls that the submerged state, when people are getting things from the state, from the government, but don't realize that's the source and attribute it to the private market. One of the things we know about policy submersion is that it demobilizes people. No need in sort of fighting against the government or going out and voting or contacting your political official if you think that this is really about your interaction with a private company. And so to the extent that Medicaid managed care introduces additional actors that sends beneficiaries conflicting signals about who is responsible and who's accountable, it makes it more difficult for them to know that political engagement is the right response to some sort of problem with Medicaid, and to know, even when they're interested in responding, who they should be targeting. And that's kind of, I think, one of the main factors related to managed care, is that it makes the political picture a lot more complex for beneficiaries who already don't always have the time or wherewithal to deal with the complexity that exists, right? Never mind added layers of complexity, because now you have to be able to differentiate between the federal government's role, the state government's role, your local, Medicaid agency's role, and then managed care organizations' role. That's a lot of different cooks in the kitchen, and many beneficiaries can't make heads or tails of it. And so that's another kind of mechanism for causing disengagement. Are we all done?
I'm sorry, I was on mute. Thank you very much, Dr. Michener, for presenting and sharing this with us. It's a lot to absorb and a little bit scary, but also gives us lots of reason to double down on our work. So we'll clearly need to have you back to tell us what else you've learned. and to hopefully have more of a conversation. But thank you so much, and thank you to everyone who's joined us today.
Thank you. Thanks a lot.
Okay.